ophthalmology and strabismus. We have an interesting program with outstanding speakers. The co-chairman is Subhash Dadaya, convener is Yogesh Sukla, co-convener Kalpana Narendran, and the moderator is Shashikant Shetty. So how would you like, would the moderator like to take over and introduce the speakers? Or would you like well, I'll introduce the first speaker, the management of retinal detachment-related strabismus. A speaker from Taiwan is Professor Anguo Wang. Anguo, over to you. Thank you very much.
Thank you, Frank. Okay, I would like to thank the APS-POS for inviting me to join this program. And today I'm going to talk about the management of the RD-related strabismus. And I have no financial interest or relationship to disclose. I think the transient strabismus following retinal detachment surgery occurs up to 50 to 60% of patients, but most of them will resolve within several months. Only 5% of patients will experience persistent diplopia after 3 months. And the preoperative examination is really important. That can, including the slit lamp, that can check the buccal position and also the range of motion, and the force reduction test can help us to check the severity and also the field of restriction. And the imaging test can help to check the buccal position. We have several buccal materials here, and you can see that there is a solid silicone rubber band or tire, and also porous silicone sponge, and also hydrogel. Hydrogel is a hydrophilic copolymer. It was used as an explant from 1981 to 1996. And as you can see on your left-hand side, there is a hydrogel. That's with the commercial name of the Miragel. And in the middle, that's the porous silicone sponge, 505 or 507. On your right-hand side, that's the solid silicone band, 240, and the silicone tire, 276. Image study can help to detect different buccal materials. On your left-hand side, you can see that the hydrogel is hypo-intense on T1 weighted image, and that will be hyper-intense on the T2 weighted image. And it would be iso-intense on the CT scan. And in the middle part, that's the silicone sponge. You can see that would be hypo-intense over here on the CT scan. And the silicone tire or silicone band would be hyper-intense on on the CT scan. And whether to remove the buccal is still controversial. And there are several studies published. In 2013, there's a study from the Emory Eye Center, and they will have 18 patients, and they report the success rate would be 62.5% with buccal removal. However, the success rate will drop to 10% only without buccal removal. Another study at the Julian Sten Eye Institute, they have 25 patients. They report an overall success rate for about 72%, and they conclude that removing the scleral buccal did not improve the outcome. What would be the effect of the buccal on the strabismus? I think, first of all, the first kind of effect is that like a hydrogel, it will, with the time pass, it will swelling up with hydration, and it will cause a mechanical mass effect. If that was located in the inferior part, that will shift the eyeball upward and cause a limitation of infraduction. And also, if you are implanting an explant onto the eyeball, it may cause disturbing of the surrounding soft tissue, and that may cause an adhesion effect. If that adhesion was located in downward, then that will drag the eyeball a little bit downward, and cause a limitation of supraduction. And the third condition is that with the time pass, they will develop some kind of the fibrous capsule around these buccal materials. And this fibrous capsule will also include the extraocular muscle, and it will cause adhesion of the extraocular muscle to the underlying sclera both at the anterior or posterior margin of the buccal. That will cause a fading effect of the extraocular muscles. Let's look at the case one. That would be a 52-year-old male patient, and he had received buccal in the left eye 18 years ago. You can see here is the buccal material over here, and it was located inferior to the left eye, and it's swelling up, so that would be a hydrogel buccal, and there would be a over 30% diopter of left hypertropia with severe limitation of infraduction in this left eye. So we decide to remove the explant. And here is the picture 4 months after the operation. You can see he is orthophoric in primary position, and the infraduction improved a lot as compared with the preoperative pictures on your right-hand side. And so the long-term complication of the hydrogel will be the hydration of the buccal with erosion or extrusion of the explant, and it can migrate anteriorly and cause a optical mass effect. And with the time pass, it will become extremely friable and fragment easily when you are trying to remove it. Let's look at this is a case of the hydrogel. We are trying to open the fibrous capsule around the buccal, and here is the superior rectus muscle we are tracking, and we will open the capsule and remove the hydrogel buccal with a muscle hook piece by piece, and must be very careful not to damage the underlying tissues over there. So it will be very friable. In the past time, there is a literature reporting that you can use a cryoprobe to extract the hydrogel buccal in one piece. Personally, I don't have that kind of experience. I usually will take out this hydrogel buccal piece by piece and carefully. And in the end, this would be the lateral side, another side of the superior rectus muscle, and try to remove the, make an opening of the fibrous capsule first and try to remove the residual hydrogel buccal. At the end of surgery, I will usually use some BSS to irrigate this fibrous capsule and to flush out all the residual explant. Okay, case two is a 48-year-old male patient, and he had received the buccal surgery in the right eye. From the CT lamp, you can see the buccal was located in the inferior temporal region, and it caused an adhesion effect. So the right eye is hypertropic to the left eye, and he had a limitation of supraduction in the right eye. So there will be about 20% of the right hypertropia and also some isotropia in the right eye. And first, we decide to remove the explant first. And however, 3 months after the operation, you can see that there is not much effect. The eye is still hypertropic in the right eye and also isotropic. And there's still limitation of supraduction after the operation. So we have to go on for the second stage of operation. That would be the resection of the medial rectus muscle and also resection of the inferior rectus muscle. And that would be the picture of 2 years after the second operation. You can see he is orthophoric in primary position, and however, there is still some mild limitation of supraduction in the right eye. So in most cases of the silicone buccal, removing the silicone buccal did not improve the surgical outcome. However, if there is a severe restriction associated with an enlarged buccal, such as the hydrogel buccal, it would be better to remove it before other strabismus procedures. And on the other hand, we should emphasize the risk of the RD recurrence if the buccal is done less than 2 years. For the surgical tip for the buccal-related strabismus, first we need to careful dissection and relieve the scar tissue or adhesion between the muscle and the underlying tissue. And it is important to avoid injury to the muscle. And sometimes it would be necessary to expose the buccal to free up the muscle. And even sometimes you need to remove part of the buccal to free up the muscle. For resection, the muscle is attached to the insertion site. For the incision surgery, the muscle was suspended over the buccal with handbag or adjustable suture, and sometimes even suture directly onto the buccal. And for suction testing at the conclusion of the operation is important to examine if there is still some residual restrictions. Here is a case of another patient, and she has already received removal of the silicone sponge, and we now are trying to recess the lateral rectus muscle. First, we will make a cut to relieve the restriction along superior and inferior margin of the lateral rectus muscle. Then we try to detach the superior rectus lateral rectus muscle. So we make a suture on the muscle and then detach it, and then as you can see that we have found a severe adhesion between the extraocular muscle and the underlying sclera tissue just behind the posterior margin of the silicone sponge. So we need to dissect very carefully to remove the adhesion between the muscle and the underlying sclera, so that we can recess the lateral rectus muscle afterwards. So we must be very careful not to damage the muscle. So in summary, the need to remove the scleral buccal is still controversial. In most cases, the silicone buccal could be left in place, but the hydrogel buccal is suggested to be removed. And we need to do the careful dissection and relieving the scar tissue or adhesion between muscle and the underlying tissue. And we should try to avoid the injury to the muscle, and sometimes it would be necessary to expose or even remove part of the buccal to free up the muscle. And the force suction at the conclusion of the operation is very important. Thank you for your attention.
Much for the presentation.
Frank, your audio is not good.
Sorry. Thank you
can't
very
hear
much for the presentation. The schedule I was given that the discussion will be at the end of after all the presentations. So we'll go through the presentations, and then there should be adequate time to discuss all the papers. The next paper is Management of Strabismus Associated with Craniosynostosis, Professor Wei Zhang from China.
Where is the slide? Can you see my slide?
Yes,
Professor
thank you.
Yes.
Yes, thank you.
Okay. Okay, distinguished chairperson, Professor Frank Martin, Professor Dadia, and my dear colleagues, it's my great honor to be invited to give a talk at this wonderful conference. And the topic I'd like to talk is management of strabismus associated with craniosynostosis. Children with congenital malformations involving cranial structures are at high risk for ocular anomalies. And craniosynostosis is one of cranial structural malformation combined with ocular anomalies. Craniosynostosis is a premature closure of one or more cranial sutures in the embryonic period or early childhood. And sagittal suture and most unilateral corneal suture are the most common seen in craniosynostosis. And 1/3 are syndromic plus face limb malformation. And the incidence is in 1 in 2,500 births. And mostly are coronal suture, sagittal suture, and lambdoidal suture. And the involved suture or sutures determine the shape of the screw, and the figure A showed us normal suture. Bone growth occurs as a suture. with bone laid down and parallel and perpendicular to the direction of the suture. And the figure B shows us virtual law. Prematurely fused suture allows bone growth only in the parallel direction. Perpendicular growth is inhibited. And the figure C is an example of virtual law. Premature closure of the sagittal suture produce the scaphocephaly. That means bolt, so skull become narrow. And varying patterns of premature suture closure may result in a wide spectrum of skull shape, and including plagiocephaly, means oblique height, is the most common in craniosynostosis, and brachycephaly or microcephaly means short height, and scaphocephaly means bold height, and oxycephaly, clear-blood shadow. Clear-blood shadow is German language, means clover leaf skull. All suture premature closed, and sometimes mental retardation may be present. Ocular complications of craniosynostosis include poor vision, sometimes myopia, amblyopia, or astigmatism, and pupil edema or optic atrophy, protopsis, and strabismus. And the strabismus may be seen up to 90% of craniosynostosis, which result from changes in orbit axis and angulation. And normally the deviation is the horizontal deviation, axial deviation, and isol deviation. Normally, axial deviation is more than isol deviation. And half have marked V pattern because of desagittalization of supraoblique or exactly rotated of extraocular muscle. I will show a few cases. The first one is unilateral chronosynostosis. And the female, 22 months old, exotropia and hypertropia since she was born. And the medical history includes congenital developmental defect, hearing impairment, atrial septal defect, and no strabismus surgery before. Here is ocular examination. Ocular motility is inferior oblique overreaction +2, and the supraoblique underreaction -2. And the deviation in primary position is exotropia 25 prism diopter and left hypertropia 20 prism diopter. And the same between the near and the distance. And from this picture, we can see the ipsilateral frontal parietal retrusion, and on the other hand, contralateral frontal parietal protrusion. And the CT scan showed us the same results, ipsilateral frontal parietal retrusion on the left side, and on the other side, contralateral frontal parietal protrusion. And the 3D reconstruction of skull showed us the similar result, the ipsilateral frontal parietal flattening on the left side, and we can see the left coronal suture premature closed, and the contralateral frontal parietal bulging. And the 3D reconstruction of orbit showed us left orbit deformed, and the orbit room becomes shortened. And the coronal CT showed us abnormally inserted ocular muscle, and the left superior rectus shifted temporally, and left inferior rectus shifted nasally, which is secondary to exactly torsion of orbit. So the patients showed a very significant V pattern, and the inferior oblique overreaction, superior oblique underreaction. When she looked up, exotropia is 30 prism diopter, and when she looked down, the exotropia is 10 prism diopter. So I did left superior oblique tack, and after surgery, the V pattern improved a lot. But 6 months later, the V pattern repattern again, and we can see the left inferior oblique overreaction. So I did the left inferior oblique myectomy, and after surgery, the V pattern disappeared. The second case is Crouzon syndrome, 5 years old male, and apparent proptosis and strabismus since birth, and the boy had a skull reconstruction surgery 6 months ago before he went to the eye hospital. And this picture is a 3D reconstruction, pre-skull reconstruction surgery. We can see the shape of school is irregular, craniosynostosis present, and all suture closed prematurely. Both side coronal suture and the sagittal suture and the lamboid suture on the back of the skull, all suture closed prematurely. And this is 3D reconstruction CT post-skull reconstruction surgery. We can see the shape of skull change regularly. And here is the ocular examination. We can see the inferior oblique overreaction +2 and the superior oblique underreaction -1. And the exotropia is 18 present diopter and the right hypertropia 10 present diopter. And the deviation is similar between the distance and the near. And the V pattern, inferior oblique overreaction. So what's the next surgery? Normally in craniosynostosis, the patients have to face two surgery, craniofacial plastic surgery and the strabismus surgery after the skull reconstruction surgery. The boys' patient read some medical literature and themselves went to the children's hospital to observe, and they consult with the craniofacial reconstructive surgeon. Finally, they give up craniofacial plastic surgeon. On the one hand, the craniofacial deformation of the boy is not severe. On the other hand, they don't want their boy to be suffered from this cranial traction at 3 or 6 months. So I did strabismus surgery, 1 month post-operation, 1 year post-operation. So the management of craniosynostosis is complex and multidisciplinary should be considered, at least include skull reconstruction surgery, craniofacial plastic surgery, and the strabismus surgery. Skull reconstruction surgery, if the severe craniosynostosis should be done at first, increased in craniofacial pressure in 75% of syndromic as 20% non-syndromic single suture synostosis, and raised ICP, increased pupil edema or optical atrophy, and the mental retardation. The timing is very important. Normally, the timing of the skull reconstruction surgery is between 6 months and 12 months after birth. If the surgery is too early, the patient have to face second surgery. If it's too late, the mental retardation will present. And the management of craniosynostosis of ophthalmic management include poor vision and strabismus, and up to 90% present strabismus. And patients with craniosynostosis showed horizontal deviation in perimeter position. Normally, exotropia is more than isotropia. And if V pattern and elevation or depression in AD duction, inferior oblique weakening procedure or superior oblique stressing procedure should be considered. And on the same time, RNR should be done to correct primary horizontal deviation. Summary: craniosynostosis is premature closure of one or more cranial suture in the embryonic period or early childhood. And craniosynostosis normally involve craniofacial, and ocular anomalies, for example, strabismus. Therefore, neurosurgeon, craniofacial plastic surgeon, and ophthalmologist should take coordinated roles in the treatment of craniosynostosis. Finally, equally important, children with craniosynostosis are often shunned or sneered by others, so much more care should be given to them by society, school, or parents. That's all. Thank you for your attention. Thank you so much.
Dr. V. Zhang, can we ask some questions?
Yes, thank you.
Yeah, actually, you said most of the time, can you, like as Dr. Brodsky has put it, whether we can declassify plagiocephaly as decompressive as well as synostotic plagiocephaly, and what can be the differences between the decompressive type as well as synostotic type of plagiocephaly? And second thing is the first case what you showed as a superior oblique tuck with the inferior oblique myectomy, that would actually cripple his up gaze, because both the this thing, because superior oblique tuck again we might create a Brown syndrome, and the inferior oblique myectomy again might create a limitation of elevation, and both procedures may aggravate this intorsion, because desagittalization of the superior oblique actually increases the intorsional factor of the superior oblique, and I don't know whether this intorsion may affect the stereoscopic vision of the child and may cause amblyopia because of this uncorrected intorsion.
For the first case, I performed the superior oblique tucking at first, but in the long run, after 6 months, the V pattern represent again. So I did inferior oblique myectomy. So in my experience, I think inferior oblique myectomy is stable in long time. So for the second case, I did inferior oblique myectomy instead of superior oblique tucking.
And can we differentiate between decompressive type of plagiocephaly with cyanostotic type of plagiocephaly, as Dr. Brodsky puts it?
Sorry?
Can we differentiate plagiocephaly between like decompressive as well as cyanostotic plagiocephaly? Are both the same or both are different?
Could we leave the question till could you send him the question in writing, please?
Yes.
Thank you very much. We'll move on to our third speaker, Professor Miho Sato. She will address us on treatment of acquired superior oblique palsy. Thank you very much, Miho.
Hello, everybody. Thank you very much for inviting me to this distinct, beautiful meeting. I enjoyed the virtual meeting very much. Today, my topic is treatment of acquired superior oblique palsy. Superior oblique palsy is one of the most common causes of vertical deviation in children and adults. And there are two types, congenital and acquired. Today, I'm going to focus on acquired superior oblique palsy. The causes for acquired superior oblique palsy are trauma, vascular diseases, idiopathic, tumor, and iatrogenic. And within these causes, trauma cases are most difficult in diagnosis and treatment. How to diagnose acquired superior oblique palsy? Park's three-step test is the most popular way to diagnose a three-step test. But recently, magnetic resonance imaging are more powerful tool to confirm the superior oblique shape and function. Interestingly, sensitivity of three-step test is only 70% of MRI positive superior oblique palsy patients fulfill. That means rest of 30% of patients who is diagnosed as a three-step test with MRI are not positive in three-step test. Moreover, Birshovsky-Hertel test for diagnosing bilateral superior oblique palsy is very poor. Park's three-step test is sensitive, only 24% of diagnosed by objective bilateral fundus extorsion. On the contrary, subjective net bilateral extorsion over 10 degrees on Lancaster red-green test straight ahead, its sensitivity is quite high. So the bilateral acquired superior oblique palsy is very difficult to diagnose clinically because they have small vertical deviation in primary position, V pattern, and large torsional deviation exceeding usually 15 degrees. So we cannot miss bilateral superior oblique palsy after head trauma. We need to check the torsion. So how to evaluate the cyclotorsion? This is an instrument developed by Dr. Hayashi in Japan. It's a kind of double Maddox rod test, but this instrument has very fine scales with 1 degree interval, and patient can rotate the dial and fix the angle of 2 lines to parallel. So it is quite subjective and very precise. This is a synoptophore. We use this for measuring the 9 gauge of position of cyclotorsion. Also, fundus photos is useful to evaluate the torsion. When the fovea locates below the line of the optic nerve head, it means excyclotorsion. And when the fovea locates higher than the center of the optic nerve, it means encyclotorsion. How to treat a bilateral or unilateral superior oblique palsy, acquired superior oblique palsy? Prisms, it do not correct the cyclotorsion, but when the amount of horizontal, vertical, and torsional deviation is small, still we can use the prisms. Correct vertical deviation and horizontal deviation with prisms. Patient may fuse with small cyclotorsion. So we wait 6 months and winning the power to wait a spontaneous recovery. But after 6 months, if the patient still has the torsional diplopia, we go for surgery. This is a very popular procedure to correct cyclotorsion without changing the vertical deviation, named Harada-Ito procedure, published in 1964. This procedure is anteriorized anterior part of the superior oblique tendon for correcting cyclotorsion. Interestingly, in original article, they published both inferior oblique and superior oblique surgeries. Recess the anterior part of inferior oblique tendon for correcting cyclotorsion is also published, but only the superior oblique tendon anteriorization became popular in worldwide. How are the other procedures to correct cyclotorsion? Inferior oblique weakening procedure is strong and stable technique. Myectomy, recession, anterior transposition, and even nasal and anterior transposition is developed, and it is a very strong power to correct cyclotorsion. Superior oblique strengthening can be full tendon tucking and also Harada-Ito. I would like to emphasize that the effectiveness of a contralateral inferior rectus muscle weakening procedure. It can be recessed with or without nasal transposition. Inferior rectus muscle recession with nasal transposition is developed by von Norden in 1996. He reported the effectiveness about 5.8 degrees. And recently, Dr. Okamoto performed on 90 cases, and the effectiveness is quite similar. We measured the 9 gauge of cyclotorsion in 6 patients. In the primary position, average cyclotorsion is 12.8 degrees. But in down gaze, the cyclotorsion increased to up to 20 degrees. We performed bilateral inferior rectus muscle recession with a half muscle wide shift. Post-operatively, the cyclotorsion in primary position decreased to 2.7 and in down gaze 4.7. That means that this technique had effectiveness in 10 degrees in primary position and 15 degrees in down gaze. Look at this patient. This patient has a large extorsion for 30 years without diagnosed after closed head trauma. There are very little eye movement disorder, and this patient was not complained double vision for a long time, but not understood. This is his head chart. He has a significant V pattern, and fundus photo showed severe Exotropia. And this is the cinnamon MRI in corona, and both superior oblique muscle were small and did not functioning with up gaze and down gaze. This is a synoptophore with 9 gaze. His cyclotorsion in the primary position was 32 degrees, and it increased to 38 degrees. We decided to perform bilateral inferior oblique myectomy and bilateral inferior rectus muscle recession with nasal transposition. This is pre- and post-operative head chart. His V pattern improved quite a lot after 12 months post-operatively. And fundus photo increased, became very normal, and also the 9 gaze of cyclotorsion decreased into primary position to 2 degrees, and in down gaze only 7. This is a single binocular visual field, 1 week post-op and 12 months post-op. Here is the comparison between inferior rectus muscle recession with nasal transposition versus Harada-Ito. Compared to Harada-Ito procedure, inferior rectus muscle recession is easy to perform and can be adjustable and easy to reoperate and correct both vertical deviation and torsion with 1 session. The problem is late overcorrection may be possible, but on the Harada-Ito, a late undercorrection is a problem. There is no randomized control trial to date, so we can choose either way. So the take-home messages, check torsion after head trauma. Try Prism first. Inferior rectus muscle recession with nasal transposition is very powerful tool and easy to perform. Can be combined with inferior oblique muscle weakening procedure or Harada-Ito procedure. Thank you very much for your attention.
Thank you very much, Miho, for a very clear presentation on a very difficult subject. We'll move on to another difficult strabismus management problem, the management of third nerve palsy. And we have Professor Rohit Saxena, who will present on this topic. Thank you very much, Rohit.
Thank you, Professor Martin. Can you see my slides?
Yes.
Yes.
Thank you. So, as Professor Martin has said, management of third nerve palsy can be quite a challenge as 4 of the 6 muscles moving the eye are affected, and we do have rather little to go by. So we'll try and see what are the options currently available for the management of a patient of third nerve palsy. So the basic options we would have are a maximal or a supramaximal recess resect procedure of the horizontal recti, which could be done on the same or in the other eye. We can do a lateral rectus periosteal fixation to remove all the action of the lateral rectus and do a large medial rectus resection. We can do a globe anchor to the medial orbital wall along with a large lateral rectus recession, or we could do a medial transposition of the lateral rectus. So we'll just see now that all these options are there, where we could use each one of them. So in a case where there is an incomplete third nerve palsy or there is some good function of the medial rectus, we could think in terms of going for a recess resect procedure. So in this case, you can see that there is a good medial rectus function. The eye is crossing the midline. We went ahead to do an ipsilateral supramaximal recess resect procedure. So a supramaximal meaning more than what we would have normally done in a comitant squint. So we have a pre-existing incomitance and we try and correct that by doing a supramaximal recess resect procedure. Sometimes we have the benefit of an aberrant regeneration. So with good medial rectus function. So in this case, you can see that there is significant ptosis, but on attempted adduction, you can see the lid retracts because of some misdirected fibers, post-traumatic third nerve palsy. So this is something we could make use of if the patient is willing. So instead of operating the same eye for a supramaximal recess resect procedure, we can operate the contralateral eye. So we operated the other eye with, again, a very large recess resect procedure. And you can see that along with the correction of the deviation, you get an improvement in the ptosis. So if there is aberrant regeneration, and if the patient is willing, because sometimes they are not willing to operate the what they call the better eye, so you could think in terms of correcting the ptosis, because in a patient of third nerve palsy, especially if the elevation function is affected, you may have a challenge in correcting the ptosis later on. Now, if you have a virtually complete third nerve palsy with very poor medial rectus function, that is the eye is not able to even cross the midline, you may want to recess or remove the function of the lateral rectus completely. And that option is available, that you can anchor to the periosteum of the lateral orbital wall instead of a large lateral rectus recession, which can be a challenge and a risk for perforation. So you completely remove the action of the lateral rectus, and along with that, you can do a medial rectus resection. Again, it is usually supramaximal, and hope to get alignment. So this was a case. You can see there is some function of the medial rectus. The eye is adducting to a certain extent, although still does not cross the midline. In this case, we did the lateral rectus periosteal fixation with a large medial rectus resection. You are able to get a fair amount of alignment in the primary gaze. However, if there is no function of the medial rectus, so you can see the deviation in primary gaze and attempted adduction, there is hardly any movement. So in such a case, we did attempt the lateral rectus periosteal fixation with a large medial rectus resection. Unfortunately, the outcomes were suboptimal. You can see that because there is virtually no action in the medial rectus, even here you can see no improvement in adduction, the outcomes would remain poor. So what are the options in cases of a complete oculomotor nerve palsy or a complete medial rectus palsy? So you have globe fixation procedures to the medial orbital wall, where you can have various approaches, including the DCR approach, the precurruncular approach we prefer, or the retro or the transcurricular approach, popularized by Moorfields. You can use fascia lata, you can use the orbital periosteal flaps. And the other option is transposition of the lateral rectus to the medial side or adjacent to the medial rectus. So again, this is the precurruncular approach we use. We prefer this because this gives us a very straight entry to the periosteal wall, and we can easily pass at non-absorbable sutures and tie them here. So this is the precurruncular approach, and we found this to be very, very effective in correcting even very large deviations. So in this case, you can see that it's a very large deviation, a complete third nerve palsy with virtually no medial rectus function. And by doing a large lateral rectus recession to free the forced suction test and doing a medial orbital wall periosteal fixation, you can see that the alignment is very good, although of course you do not get significant adduction or abduction. So that is a downside of this procedure. And if there is preoperative significant abduction or adduction, then you may think of alternate procedures. The newer procedure, which now of course has been significantly, is very popular and has been done by a lot of surgeons, is the transposition of the lateral rectus to the medial side. And this was originally described by Taylor and Kaufman, and Gokigit was the one who reintroduced it. And there were limitations to this. The most important was that transposing it medially still gave suboptimal results. So while Jasprit from India actually did a medial rectus resection along with it, we modified the transposition procedure and added a posterior fixation suture to the transposed two slips of the medial rectus, of the lateral rectus superior and inferiorly, so that you have a much larger transfer of the force vector. And these are some of the cases you can see that significant deviation which gets corrected post-operatively. Another patient, you can see again good post-operative alignment. If you have a vertical deviation along with a large horizontal deviation, the split lateral rectus transposition to the medial rectus will not correct for the vertical deviation. So we tried a full tendon transposition from the side opposite to the direction of deviation. So in this case, there was a exo with a hypertropia, and we shifted the entire lateral rectus through the inferior root to the medial side. So you can see it significantly corrects the vertical deviation along with the horizontal correction, although the horizontal correction we felt was suboptimal, not as great as what you would see in the split transposition procedure. Another patient, you can see there was significant hypotropia along with the exotropia. And in this, we did the transposition from the superior root, that is underneath, transferred the lateral rectus underneath the superior rectus and the superior oblique medially to get, again, a good vertical correction and fairly good adduction or fairly good primary gaze alignment. The only downside of a transposition procedure was that it was a rather a fixed procedure, especially if we are planning an augmentation of the transposition. So we tried to enhance the transposition by crossing it underneath and making it adjustable. So this was the procedure. So the lateral rectus is split, transferred from underneath the superior oblique superior rectus and the inferior slip underneath the inferior oblique inferior rectus medially, and then it is crossed underneath the medial rectus so that the inferior slip is inserted superior to the medial rectus and the superior slip inserted underneath inferior to the medial rectus on sutures that are adjustable. So we used the short tag nose technique to make this process adjustable. And most of the time, just by adjusting it intraoperatively, we are able to get very good post-operative alignment. So another patient, you can see the preoperative and the post-operative correction. Again, you can even adjust the vertical deviation by loosening or tightening the side of sutures you want to correct for the vertical. So again, in this case, you can see there was significant hypotropia also along with the exotropia, and by adjusting it intraoperatively, we were able to get good post-op correction. So to summarize, now we have a lot of options for management of third nerve palsy. We need to see whether it's complete or incomplete and assess the function of the medial rectus. We need to look for any aberrant regeneration, which would help us in management, especially for the ptosis. You need to see if the patient, of course, is willing for other eye surgery, and finally choose appropriate surgery depending upon the function of the medial rectus you have. I prefer the lateral rectus split transposition medially when there are vertical deviations, which I can correct in the same procedure. And I prefer the medial periosteal anchor if the forced suction test is positive, that is the lateral rectus is tight, or in cases for resurgery. Thank you very much for the opportunity.
Thank you very much, Rohit. Once again, another very clear lecture outlining how a most challenging problem can be managed. We'll move on to strabismus with thyroid eye disease. We have Professor Sumita Aggarkar. Sumita, welcome.
Sumita, unmute yourself.
Sumita, we're unable to hear you.
Morning, everyone.
Welcome. Thank you.
Thank you for pointing out, Rohit. So I'm going to talk on management of strabismus in thyroid eye disease. So it's thyroid eye disease basically has two clear phases. There is an acute inflammatory phase with a lymphocytic infiltration and congestion of the orbital tissue, which if the patient presents at that time can have pain, ocular movement restriction and diplopia, and then it leads to a chronic phase later on with adipose tissue infiltration and fibrotic changes of the ocular muscles leading to restrictive strabismus. So it affects nearly, different studies quote different numbers, but anywhere from 17 to 51% of the patients with thyroid eye disease are likely to have strabismus. However, I don't know if I'm wrong here, but we seem to see less strabismus in thyroid patients from India. I don't see it as much as it is reported in the Western literature. Risk factors, again, middle age, women, smoking. Smoking is a very, very important risk factors, and this study by Rajendran et al. has reported that who are smokers with thyroid eye disease are twice as likely to need strabismus surgery. And of course, some amount of family history and genetics also plays a role in this thing. So this is the usual clinical presentation: proptosis, lid retractions, isotropia, sometimes orbital, not sometimes, very often compressive neuropathy, and other corneal involvement in severe cases. Etopathogenesis probably autoimmune, but other factors which can interplay are genetic factors, environmental factors like smoking, type of thyroid eye disease, type of thyroid disorder, and of course the immune response. So this is another typical patient who will sometimes motility limitation can be both vertical as well as horizontal, as you can see in this patient, has isotropia as well as hypertropia in the affected eye. It can be symmetrical as well as asymmetrical, and almost world over, inferior rectus is most commonly involved muscle, followed by medial rectus, though other muscles rarely can be involved like superior rectus, lateral rectus, and even obliques. Inferior rectus, probably because it is very bulky and tonically active muscle, is probably most prone for inflammatory changes and the fibrotic changes which result from thyroid eye disease. As I said, individual muscle involvement can be unpredictable. It can be asynchronous as well as asymmetric. But the hallmark of myopathy is almost always a restriction at a later stage. These are the investigations which you would like to do in these patients. Imaging is very important, and it shows very clearly the tendon sparing fusiform enlargement of the muscle, and a short tau inversion recovery MRIs often give you a clue about disease activity, which plays an important role in timing of the surgery, especially strabismus surgery. It demonstrates your muscle involvement and also gives you an idea about the optic nerve status, compression of the optic nerve. CT scan or ultrasounds also can be done, but they are less helpful. So this is a typical MRI which shows T2A image, which shows bulky muscle, and you can see here inferior rectus is really enlarged as well as the medial rectus. These are the differential diagnosis. Myasthenia gravis can really coexist as well as can mimic thyroid ophthalmopathy, and this needs to be ruled out. In silent orbitopathy, sometimes can mimic cranial nerve palsies, and of course other inflammatory conditions like myositis and orbital inflammation. Idiopathic orbital inflammations can also mimic thyroid eye disease. Management is usually divided into non-surgical and surgical, and these are the options in the non-surgical management. You can have medical management in terms of steroids, which are very effective in controlling the inflammation, but are less effective in controlling or alleviating the diplopia which these patients may have in the active phase of the disease. Radiation has been tried. Botulinum toxin has again, there is a renewed interest in the botulinum toxin. Prisms can be given in active phase and sometimes can be a definitive treatment for small angle strabismus. And recently, teprotumumab, which is a insulin growth factor receptor 1 antibody, which acts on that, and is has given a very, very hopeful treatment option for patients who are in active phase of the disease in terms of both proptosis as well as diplopia and the quality of life. So as I said earlier, prisms can be a definitive treatment in small angle. It can be both Fresnel or ground-in prisms, and it can be also be tried in patients who are waiting for surgery. Botulinum toxins, recurrent injections may be required. Difficulty in precise delivering the agent within the orbit with a very enlarged inflamed orbit is difficult, but it can be a choice in poor surgical candidates which cannot be treated with prisms. So up to 5 units of dosage has been described in the literature, and often more than one injection may be required, and it is probably ineffective when the muscles are already fibrotic. So these are the surgery indications, and as I said earlier, that surgery probably should be reserved for patients who are really have large angles, who have very cosmetically unacceptable strabismus, or have abnormal head positioning with intractable diplopia. So challenges of the surgery in these patients are because variable outcomes. We don't have very good ways to assess how active is the disease. Muscles can be tight, bulky. Conjunctiva is often friable and tends to tear. There is concomitance, especially sometimes even between the primary and the down gaze. And surgical dose calculation is always a challenge in these patients. So here our surgical goals should be clearly to achieve substantial field of binocular single vision. And we really focus on primary gaze and the down gaze. And if possible, sometimes now the goals have been enlarged to just enlarge the binocular diplopia free field can also be considered as a acceptable goal of surgery. So surgical dose calculation, we follow this dictum by Jampolsky, and smaller angles often need larger recessions and larger angle need smaller recession compared to traditional strabismus surgery, where it's almost the opposite. Timing of surgery, it has to be either stable angles for at least 6 months, or if the disease is quiescent. And if orbital decompression is planned, you plan strabismus surgery after that. And of course, muscle edema using T2 weighted images also can be a marker for stability of the disease. But despite that, sometimes patients have had continued activity despite showing quiescent disease on MRI. So that needs to be talked to the patient. So surgery, usually it's the recession of the tighter muscles, and resection is usually better avoided, but may have to be considered in large angles, as in this paper which has reported. So sometimes resections, we do employ resections for significant residual esotropia or hypotropia after we have recessed the muscles. And adjustable sutures, again, a little bit of a controversial thing, because adjustable sutures sometimes tend to cause late overcorrections, as well as a little bit of slippage of muscles is common in these patients with bulky muscles. Inferior rectus, again, definitely, probably the consensus is to avoid adjustable sutures, and probably a non-absorbable sutures probably give better surgical results. So when you plan surgery, patient counseling is very important, realistic expectations, and you have to counsel the patients that proptosis and lid retraction may actually worsen after surgery. Multiple surgeries may be required. This is an important thing. Even after strabismus is corrected, these patients' reoperation rates can increase over the time. When we are considering, we have to consider all three primary, secondary, and tertiary actions of the each muscle, and are important to take into the account fusional range consideration to see if there is a previously hypotropic muscle with a small hypodeviation. Ocular torsion is very important, especially if you're dealing with inferior rectus in these patients. So this is important to document, and a lot of times more than the angle measurements, probably post-action test on the table is probably more important than anything else in surgical decision making. So intraoperatively, as I said earlier, post-actions at the beginning of surgery and probably after muscle is disinserted also. Large muscle recession also should be combined with conjunctival recessions to avoid post-operative restriction through conjunctival tethering, and a good dissection of Tenon's capsule in and around the inferior rectus muscle is really important. Challenges during surgery, friable conjunctiva, muscles are tight and pulled in two syndrome has been reported. You can use special hooks like Wright's hook or Wilson's hook to use these, hook these muscles. Sometimes a 15 Bart Parker knife blade is required to cut these muscles, because it's not possible to insert a tenotomy scissor under these muscles. And sometimes hangback approach is semi-adjustable hangback approach is better for larger recessions. So these are the two things. This is a Fechner faucet, which you can use to hold the conjunctiva, because this conjunctiva really tends to cut through, and a double is sometimes important if you're doing recession. This allows us to create some space between the muscle and the sclera to insert your scissors. Intraoperative relaxed muscle technique, which has been proposed by Del Canto, has been very useful. And once the muscle is disinserted, it is allowed to slip back to as much possible in the globe, and with the globe held in primary position. And this has proved the surgical success rate of much superior to traditional recessions. So surgical outcomes can, in this patient, as you can see, is a very large hypo in the left eye. And I'm sorry, but picture is a little bit reversed. We did operate on the left eye only. And as you can see, with just one inferior rectus recession, patient has, of that too not very large, some 5 millimeter recession, we were able to give him diplopia free field with not much restriction in the down gaze, and patient was happy with just one, while as traditional teaching here we would think that you will need 2 muscle or more surgery. Complications of surgery, overcorrections, especially late overcorrections, are very common. Marked post-operative inflammation, lower lid retraction, and the most difficult to deal with is A-pattern exotropia, which these patients, especially with bilateral recessions, inferior rectus recessions, very common. So these are the reasons why inferior rectus recession can cause late overcorrection. Muscle slippage has been known, and one way of reducing the late overcorrection is to either combine it with contralateral superior rectus muscle recession using a non-absorbable suture, and to match the duction by doing a forced duction, by doing a Fardon's procedure on contralateral, and anticipating and probably talking to the patient about this problem before surgery. Eyelid retraction is also common, so a good dissection and with Lockwood ligament and lower lid retractors will probably partially solve this problem. A-pattern exotropia, again, sometimes, rarely superior oblique involvement can worsen this, so this must be kept in mind. Management is usually you can do a prism glass modification. You can reduce the amount of medial rectus recession if it is consequently planned along with inferior rectus recession, or even delaying staging it. Medially transposing the recessed inferior rectus, but this comes with a slight risk of worsening the encyclotorsion, and sometimes even minimal medial transposition of inferior rectus can also take care of, nasal transposition of exotropia can take care of it, but nasal transposition again can worsen the encyclotorsion. So sometimes it is difficult to get everything in one surgery, and you may have to counsel the patients before that. So surgical follow-up is required. 50% of these patients can end up with reoperation, which is both because of unstable or evolving disease and unpredictable results. So to summarize, surgery only if it is functionally disabling, quiescent stage only, and conservative therapy as much as trial should be given, and cessation of smoking definitely should be, because it really takes care of worsening of the disease, and maybe standard surgical nomograms to be used carefully. Intraoperative FDT, I cannot stress importance of it more. Using smaller numbers for bigger angles, recession as far as possible to avoid resection, and if at all resection is tried, it should be probably limited to the tendon and not really the muscle belly, and adjustable sutures if you are comfortable with that. Thank you for that.
Thank you very much, Sumita. We'll move now to Twain retraction syndrome, and we're fortunate to have Ramesh Kakanuya with us. I don't think anyone has more experience in this field than Ramesh. Thank you very much for joining us.
Thank you, Dr. Martin. Happy to participate here. Very warm namaste and welcome to everyone. I hope all of you are doing very well during this pandemic. Dr. Sharma asked me to talk about Duane syndrome today. In the limited time, I'll talk about how to manage isotropic, exotropic Duane, overshoot, and Duane minus a new entity. That are my objectives. If you see the patients of Duane syndrome, type 1 is the most common. But in practical terms, what is important is how many of them are orthotropic, isotropic, and exotropic. This is more important than really looking at type 1 or type 2. In addition, for me, the most important factor when you really do a surgery, these are 4 cluster of things. One is the type of Duane, ET, XT, ortho, or do they have vertical? Obviously, the amount of deviation as strabismologists, for all of us, that's the most important. The next cluster, I would say unilateral and bilateral. Type matters, probably we can discuss about it in the discussion. And the associated thing, which will not see in any of the other concomitant strabismus, that is co-contraction, retraction, overshoot, AHP, and sometimes bands. This makes Duane syndrome a little bit complicated. So we need to have a grading of these other factors. For example, grading of retraction by this, measurements. A simple measurement can be helpful in measuring the retraction, and also how much the patient has overshoot. Simple camera can really help you to quantify how much, like amount of deviation you use prism test. Even the retraction can be really measured. There are many patients with orthotropic Duane syndrome. We don't do anything, but it's good to know that they have a good accommodation, but have poor convergence, and stereopsis is noted to be poor in many of these patients. We don't do anything surgically for them, but these are the things we need to know in orthotropic Duane syndrome. There are subset of patients where there is accommodative component, especially in isotropic Duane syndrome, where a pair of glasses can really correct even the abnormal head posture and primary position deviation. This is a very small subset, but we need to be aware of that. Coming to the isotropic Duane, you can see here, this patient on the panel A, you can see abnormal head posture, very large isotropia, and abduction limitation, maybe +1 or +2 retraction. We did medial rectus recession and superior rectus transposition. That's the new thing in Duane. Not a new thing. I think it's almost a decade old now. Many of us have a lot of experience with this. So that's been done in these two patients. And additionally, you can see advantage here is correction of abnormal head posture, correction of primary position deviation. And if you see in this chart, head-to-head comparison between the medial rectus recession and abduction at the SRT, that is the monorectus transposition, there is a significant improvement in abduction, which most of our patients ask for. How much it will improve? How much it will improve? My standard answer for them using all this evidence is around, we can improve by 1 or 1.5 units, maximum by 2 units. That's if on a scale of -4, we can improve on an average by -2. That's the 50% improvement we can counsel these patients. What about bilateral? Bilateral as well. All of us know that the medial rectus is almost always tight. It amounts to very small group of Duane syndrome, 5 to 10%. Here we do a bilateral medial rectus recession. This is good. This really gives a good correction. Only thing in our experience is that we have done a little bit more than what we do for the standard infantile isotropia. But one should be very, very careful in a tight muscle where we cannot go really, really too much. Even a 0.5 can really make a difference when you are touching medial rectus. And of late, we have been doing, this is just accepted in JAPOS, we are doing bilateral medial rectus recession and bilateral superior rectus transposition in cases of bilateral isotropic Duane syndrome, which you can see improves the abduction significantly in this subset of patients. So that's an option for isotropic. When it comes to exotropia, I think in Asia, it's highly relevant. Exotropic Duane syndrome is much, I wouldn't say that it's much more common than isotropia, but it's commoner in Asia. The exotropic is very common compared to Western countries. So in this series, we had a large number of patients with exotropia. This again, we published a series of 78 patients of exotropic Duane and their surgical correction. If you can see in this busy table, what has been done, 48% of the patient we could achieve the correction just with unilateral lateral rectus recession. 25 patients needed bilateral lateral rectus. It can be symmetrical or asymmetrical. Unilateral, when there is a associated significant retraction or overshoot, add Y splitting. And sometimes we need to do bilateral lateral rectus recession with ipsilateral Y splitting. These are some of the things what we have, but there are some other things. In extreme cases of overshoot and retraction, we might have to do a differential recession of both the muscles, and we need to go into even periosteal fixation, like what Rohit explained in third nerve palsy. So this is some of the examples where we have done a unilateral or bilateral asymmetrical recession. This is the immediate post-op. One of the things, when she comes after 5 years, you can see a slight abduction limitation, which can be increasing in this patient. This we need to counsel to this patient. So that's the conclusion in most of this of type 2 or type 3 Duane syndrome. Mostly they are type 3. Exotropic is mostly are type 3 in our country, what we see. So that helps. And whenever there is overshoot, most of us will do Y splitting. There are other ways as well to handle this. This is where some of the patients, as I was explaining, I do a lateral rectus the superior rectus transposition to the LR, and also fixation to them, to the periosteum. And then you can take, it's like you can take care of two things in one surgery. So that's where we are trying to do some subset of patients that's required. And this is the post-operative picture of the same patient. It significantly improves the overshoot as well as significant exotropic Duane syndrome. So what is significant, we can discuss in our discussion. Very small subset of exotropic Duane syndrome, very small, they have vertical deviation. Here, Y split helps if it is around 5 or 6 prisms. We might have to go into inferior oblique surgery or superior rectus recession. This is one of the patients where we had to do lateral rectus and superior rectus recession, which improved the horizontal deviation. The last one I'm going to touch upon. This is in our experience in the last 15 years, we have seen subset of patients, their ocular motility is good. Maybe if you see carefully, they have some incompetence. They don't have significant overshoot or retraction, but they have all the features. When we do the typical surgery, what we really do it for Duane syndrome, it really corrects everything. The abnormal head posture, it responds really to the Duane syndrome. When we really looked at this is a series of 11 patients we have published. Duane minus, they don't have retraction, they don't have real clinical duction limitation. When you do incompetence, yes, they do have this incompetence. They can have this partial agenesis of this nerves. That's possible. That's entity we call it as Duane minus. It really responds to the typical surgery, what you do for these patients. So I show this picture. Upma, I think for some of our foreign faculty, you don't know. This is one of the most common breakfast item we have in India. There are 100 ways of doing it. Some people put some of the nuts. It's all depends upon availability. We need to look at in this Duane syndrome, you need to look at what are the available things, what you can see. And each patient is different. Here, each state can be different. Each house can be different when it comes to Upma. So that way, I think really it applies. And this is the summary slide of my last slide. It gives that Upma kind of thing. What are the recipes? When you have, isotropic, exotropic, orthotropic. This is the standard classification, what you should have. And once you have it, how do you do? When you do superior rectus transposition or periosteal, we have given that small little notes. This can really help. I'm not going to really explain everything. I think it's self-explanatory. Thank you so much for everyone for this attention. In the evening, we have a Strabismus Hall of Fame. If you are interested, you can join us. Thank you so much.
Ramesh,
Thank you. Thank you very much, Ramesh.
Can we ask some questions, Dr. Frank?
Yes, we can ask a question if we've got time.
Yeah, that Upma was mouth-watering actually. Ramesh, actually, how you deal with the near-distance disparity in patients with exoduans? Like you get more of exo for near and less of exo for distance. Then how you deal with those patients?
Yeah, near-distance disparity is, I would say it's pretty common in type 3. And sometimes type 2 is quite rare. Type 3 generally depends upon the severity. Again, if there is no retraction, Shashikant, if there is not too much of retraction, I try to do a small resection. Dr. Kraft from Toronto, he has a paper on that. But generally, I do a asymmetrical resection. So that's what I try to do, Shashikant. Generally, I do a lateral rectus resection. It takes care of it. Even in intermittent exotropia, we have that experience, right? It's not that we have to do a bilateral medial rectus resection in all the cases. Many of the patients, both the things can be managed with this symmetrical or asymmetrical resection.
Thank you very much, Ramesh. I will move on now to Professor Subhash Daya, who will speak on diagnosis and management of MED.
Very good morning, good afternoon, and good evening to everybody. Thank you, AIUS, and thank you, Asia Pacific Society, for inviting me to speak. So basically, my screen is visible?
Yes.
So basically, it is defined as inability to elevate the paretic eye from any position of gaze, provided ductions are normal in all other positions of gaze. It may be paresis of superior rectus and inferior oblique with ptosis, or superior rectus palsy of long standing. Earlier, it was known as DEP, which was coined by Dunlop. It may be congenital or acquired. It may be paretic or restrictive. It may be supranuclear. But MED is more accurate term, as paralysis of both muscles independently and supranuclear lesions can lead to impaired unilateral upgaze pulse. There could be congenital causes, supranuclear defects, superior rectus paresis, inferior rectus restriction, neonatal hypoxia. In the acquired, there may be CVS disease, midbrain tumors, then sarcoidosis, infections, and in our setting, cysticercosis is an important cause of acquired MED. This is ultrasonic picture of one of the patients of the cysticercosis who has MED. Then it is classified into type 1, type 2, and type 3. Type 1, where prominent feature is restriction of the inferior rectus. In type 2, prominently there is weakness of elevators, and in type 3, both the combined mechanism. So what are the clinical features? Limitation of elevation above midline, both in abduction and adduction, hypotropia of the involved eye, presence of ptosis and pseudotosis, chin elevation. In most of the cases, MED is unilateral. Marcus gun jaw winking phenomena is present in 25% of the patients. This is one of the photographs of the patient of MED. So for diagnosis, it is very important to ask history of onset, and if sequence of events are not clear, then presence of amyloidea suggests congenital etiology. You must look for previous photographs. For acquired causes, you must see the history of neurological symptoms, past medical records, and general systemic symptoms. In type 1 DEP, there is positive FDT, normal FGT, normal skates, and there is deeper lower lid folds, and Bell's phenomena is negative. In type 2, FDT is negative, reduced staggered velocity, there is reduced force generation, and intact Bell's and skates, they are absent above midline, which suggests a supranuclear lesion. Then in acquired DEP, it is acute acquired diplopia in upgaze. Ptosis is not a prominent feature. You will see the pupillary anomalies, convergence weakness, and neurological symptoms. It is very important to differentiate acquired from the congenital. Differential diagnosis could be Brown syndrome, vertical Twain's, congenital fibrosis of inferior rectus, congenital absence of superior rectus, inferior oblique, abnormal insertions of the muscle, and partial third node palsy. For acquired, there may be thyroid orbitopathy, myasthenia gravis, orbital fractures, third node palsy, previous cataract surgery, cerebral tumors. This is one of the patients who was having myasthenia gravis and presented as acquired MED. Then what are the indications for surgery? If there is significant abnormal head posture in primary position, that is indication for surgery. Significant vertical deviations in primary position, contracted binocular fields, diplopia in primary gaze. In most of the patients, we have to observe the patient because with limited head posture, the patient can maintain orthophoria, and treatment for double elevator palsy or MED is surgical and only surgical. The goals of surgery are to achieve cosmetically acceptable deviation in primary position, to increase field of binocular single vision, and it is very important to tell that surgery will not cure the MED. More than one surgery is required, and ptosis surgery should always be done after strabismus surgery, because most of these patients, they come with the complaint of the ptosis, and they are more concerned about the ptosis. So ptosis surgery should always be done after strabismus surgery. Optimal surgical treatment for MED remains controversial, and treatment should be according to the type of MED. Type 1, which is usually 75% of the in 75% of the patients in our setting, and recession of the involved inferior rectus is the treatment of choice for type 1. And type 2 MED, NEPS procedure is a well-established and commonly practiced procedure, but drawback of NEPS procedure is patient loses some abduction and adduction, and effectivity decreases if deviation is more than 25 prism diopter. These are the steps of the NEPS procedure. Esothenectomy with vertical muscle recession are effective according to the Chinese study. Sneer et al. Recommends NEPS procedure with posterior fixation sutures, and DP with horizontal deviation is a separate entity in which modified NEPS procedure is quite effective in our hands. This is the preoperative photograph of the patient. This is the post-operative photograph. Then another patient with preoperative MED. This is the post-operative photograph immediately after the surgery. This is another patient with the MED. You are seeing the post-operative photographs, and final picture is after the ptosis surgery, good correction. When to intervene for ptosis? You should wait at least minimum of 6 months after subsequent surgery, because magnitude of vertical correction increases with time following NEPS procedure. Thank you very much for your kind attention.
Thank you very much, Professor Tadea. The final paper in this symposium, we're moving away from strabismus, and we'll be talking about pediatric cataract surgery. And we're fortunate to have Dr. Kokar to present on this.
Thank you, Frank. And I think there's a change in the flavor now, because we're shifting from hardcore strabismus to, which is not pure strabismus, pediatric cataract. So basically, all right. Can you see my slides, please?
Yes, thank you.
Okay, so I'll start then. Okay, so sorry, I was editing them. So I think we should finish well in time so that we can catch up the Australian Open. So there are going to be a good finals today. So let's see, let the best guy win. Are my slides visible to you? Are my slides visible, please?
Yes, please put it on full screen, sir. They're visible.
Yeah, okay, thank you. So let's have a little change now, pediatric cataract surgery. Let's go and see. So during my talk, I want to cover a few things now. What is a pediatric cataract? Why does it occur? Which cases to operate? It's not that you see a speck in the eye, you can jump to operate. When to operate, how to operate, and who should operate. I think that's the last one is very important. We'll come to that a little later. So when you look at this slide, what you see is a gamut of patients. You can get patients which have a cataract at the birth, or you can have patients which have, sorry. I think I shared the wrong slides. Okay. So the pediatric cataract has an epidemiology. 1 to 15 in 10,000 births will have cataract. So that's not that rare. And this was the data which was about in 1997. What we see now is that I think the number has increased. Whatever be the factor, it could be the genetic factor, it could be the familial, it could be the consanguineous marriages, or it could be the nutrition given to the mothers during pregnancy. This is on the rise. Why is happening? We don't know exactly. So the blindness earlier used to be in 1 to 4 in 10,000 in the developed world and 5 to 15 in the developing nation. But right now I feel that it's becoming a universal thing. It's happening everywhere. Okay. So because the populations are going and they're migrating from one place to another, so you get set of patients. So what exactly is congenital cataract? It could be a congenital. When it's picked up at birth or as early as 3 to 6 months, they have nystagmus, they have squint, they're usually nuclear and polar. And the amblyopia is very, very dense in these ones. The other group could be when they start going to the school, when the parents pick it up, the vision is low, subnormal. They don't have abnormal movements like nystagmus or squint, and they're usually zonular and lamellar, and they have very good visual prognosis. It's a universal phenomena. So with this in mind, I think WHO has got Vision 2020, in which they want that each kid has to be taken seriously, because treating a child is as good as treating 10 adults. So why do we get it? The answer is we still do not know that why we get in all the patients. They could be unilateral, bilateral. The majority are idiopathic. Idiopathic, it could be sounding like idiopathic because we are still idiots. We're not able to find out why it's happening in so many people. But yes, majority of them are still idiopathic. So I think that is what we have to see. So the only thing we can do is can make the media clear in them. Okay. So there are certain associations which we've seen, and this was a paper which came from Australia, in which they found out that about 2.2 in 10,000 will have a familial or a syndromic cataracts. And these are some syndromic cataracts. I'll just show you some examples. So Nance-Horan syndrome can be easily picked up if you dilate the parents, especially the mother's eyes, and see a distant direct. And that's about it. If you do it, you can pick this up. And this was the mother's eye, which had a 6/18 vision, and she never bothered to get herself operated. Downs is the commonest syndromic cataract seen. Rubella is again on the rise. We're getting lots of patients coming with the rubella, and especially typically a microphthalmic, non-dilating pupil with a cataract which is partially absorbed, like a post-uveitic cataract is what we get in these patients. And get a cardiology evaluation, you can pick up a PDA. So which one to operate? The one which are more than 3 millimeter and blocking the central pupil. The posterior polar cataracts are the ones should be operated because they usually block the vision because they're close to the nodal point. And if the nystagmus or strabismus present, you should go and operate these patients. So this patient, on dilatation, we found a cataract, but the central part is clear, can wait. Now, these are different kinds of zonulars. You can see one zonular here, second, third, and fourth. The second and the fourth need not be operated. So in this one, you can easily pick up the first has to be operated, the fourth has to be operated. The second one, in case there's a deviation, has to be operated and keep a close follow-up. Whereas the third one, you can actually wait on this one on a strict follow-up. If you operate them very early, less than 1 month, there are always high chances of glaucoma in these patients later on. There's a high risk of apnea in these patients. So they should be operated. Ideal age is about 12 weeks, which is ideal in this one, and unilateral should be operated a little bit earlier than the bilateral. So basically, when the leukocoria patient comes to you, you have to check out whether this is in the cornea, in the lens, or in the vitreous. So these are the tests you can check out. The best test in this ultrasound, which can give you lots of information. There's a bilateral cataract. This also is a bilateral leukocoria, but this is a bilateral RD. Now, this is another sign which you can pick up. If you look at this patient's eye, you see there's opacity comes and goes. It's like a shifting, like a fleeting kind of leukocoria. So this is basically not in the lens; it's behind the lens. So that's why it's a very important sign that you need a VR guy to stand next to you. Certain investigations can be done which are tailor-made. The important thing I'm going to show you is how to do a proper EUA in these patients, because without an anesthesia examination, there's no point in operating this patient because you don't know what you're getting into. So once the child is under, you have to do a keratometry of both the eyes, and that's what is being done. We do both eyes simultaneously. After the keratometry, we start checking the white to white diameter of these eyes, because if the white to white is less than, say, 9 millimeter, in one of the meridians, then we don't put implant in these patients. So that's what is checked. And all the children have to undergo all the standard EUA technique. So once you measure both the eyes, then you can switch over to the exit length, and the contact thing should be done at the last. So you do a contact biometry with which you can pick up exit length. And at the end of all these surgeries at our center now, we do a UBM in all these patients. Even if the cul-de-sac is small, we can put is on one lid on one side and push the lid to another side with the cup, and you can actually get a good image. So that's how the UBM is done. And that's what was the paper we presented in 2019, which got an award for this UBM findings in pediatric cataract. Okay, so I'll show you some UBM findings. So this is a typical zonular cataract. You can see the central part is clear, which will be picked up on the UBM as well. Now this one has a centric calcification, which can easily be picked up on the UBM. Somebody's, I think, mic is on, please. Can you put them to mute, please? Thank you very much. Now this is the one which doesn't look like a zonular cataract. You see, looks like a partially absorbed, but on seeing the UBM, you find that the entire volume of the lens is intact. So this is not an absorbed cataract yet. Whereas this patient has a Morganian cataract, which is actually floating in the front. And this is like an entire nucleus which is floating around. Okay. Now, how to operate is very important, because the surgical concept is to clear the central area so that the light goes and stimulates the retina. That's one. Second, you have to remove all the scaffolds which can form a PCO later on. And third, even if you're not able to put the lens at this stage, you should be having enough support so that you can go in and visit again and do a secondary IOL in these ones, and should be least traumatic and minimum complications. So what you need is a surgical. So this is where my surgery starts. I start with the UBM. So this is the lens in which you can see actually there's a little loss of volume. And we do all the parameter checkup. And this was a lens which was actually very sticky cataract. So that's why I picked it up. So you make a 3 incision, all these surgeries, see that eye is trying to roll up. So I had to tell my anesthesia guy to deepen it a bit. I picked it up this important video intentionally so that you have a good liaison with your anesthesia team. And once you got 3 incision in place, you need to put a dash of air, EDRI, 1 in 10,000, and then a little bit of dye. So even if it's a clear lens, it's best to put a dye, because that will change the nature of the anterior capsule and it makes it less elastic and you can manage it well. So then when you take out the dye, you try to take out from all the openings. So I took it out, put for one and took it for the other. So I have both the markings visible there. There's no shortcut here. You need to have a good viscoelastic. I use Hilon GV for all my patients. And then you see my microscope has a Rectus assist, which tells me that's my 5mm Rectus size there. So I have to go 5mm. This is what is going to guide me. You come from the side port always and give a nick, which is going vertically down, and just lift it up a little bit and leave it there. Because if you try to go with the cystosome alone, it'll run away, because it's so elastic. To make an incision, in this one, I'm using a Utrata forceps for my anterior capsule Rectus. I'll use a longer forceps intravitreal for my posterior capsule. You can use either of purpose, depending on what kind of dexterity you have. So now this is guiding me to make a mark. Why I'm putting a 5mm mark? Because that will keep my lens at place in the bag. So my IOL will not come and get captured anteriorly if my Rectus is actually on top of that, and eventually it gets fibrous and retracts to about a 10% of its size. So 5.5mm Rectus will become 4.5 and it'll keep the lens in check and never come in the front. So once that is done, the next step is to do a hydro. In these patients, you do a hydro with your viscoelastic still inside the eye, unlike the adults. Then bimanual is the way to go. And these are the bimanuals which I use, and it is the same size which my incision is, so there's no leakage there. And if you notice, this is not a typical soft cataract which comes out in a go. It's like a putty. It's like a little leathery cataract which is there. So I'm rolling it up. I lift up the thing. In fact, the entire thing is rolled up like a boiled egg. So once that's come up, I'm going to eat it up slowly. See, my chamber is formed. The pupil does not dilate too much, but this is the size it maintained throughout the surgery. And once this is gone, then the next step is to do a posterior Rectus. And for the posterior Rectus, you have to underfill the bag. And you notice that I again go from the main incision, and I'm grasping it and going step by step. And posterior Rectus never will run away. It'll run away only in the patients in which you overfill the bag. So never overfill the bag. It's the chamber you have to form, but your Rectus, your bag has not to be overfilled. Don't push it backwards. So once this step is done, the next step is vitrectomy. And we do a high-speed cutter with the 4,000 cuts, which I use on my Centurion machine. And once the vitrectomy is done, immediately after the vitrectomy is done, the next step which I started doing now in all my patients is I go and inflate my bag And then I'll come with a illuminator from my main incision, and I go and take the picture and in fact record the fundus finding of all my patients using a wide angle, which of course the retina guys are using right, left, and center. And this is what you see. Now you can see the entire retina. So this kid is a 6 months old kid, and it will never show you the retina properly later on. So I have a data here. Now, whenever I see this, I know this was a patient who had a disc cupping. So we have come out with a paper on this also, which has been published in BMJ. I'll just show you a script of that. So we saw about 500 patients with this, and we could pick up all variety of gamut of things which can be shared. I can share the files with you if time allows later on. And the lens has to go into the bag, and the lens goes into the bag. This is a single piece going into the bag because anterior posterior rexus both are intact, so the lens will stay in the bag, and that's about it. Then you put the suture onto the main incision, and the side incision you can hydrate, and the lens stays put in the eye. Okay. So this was the wide angle recording which I was talking about. Now this is a technique which has been published in BMJ. I'll send you over the soft copy, and beautiful pictures you can see. I mean, you can see the entire gamut of everything. So you need not go into the vitreous all the way. Even if your posterior capsule intact, light can stay on the posterior capsule, and with the light off and with the inverter on, you can actually take all the retinal pictures. You can even scan the peripheries of these patients. So who should operate is very important, because recently we had a paper in which we saw 1,000 patients, and 10% of these patients had problems. 3% because of the complication of surgeries done by people outside, and there were high VO, about 7%. So about 10% people, 1 in every 100 patient will have a problem which need to be operated again. So I will prefer the people who operate these are with a trained pediatric ophthalmologic surgery, because it's not as simple as adult cataract. So they have to have a good anesthesia setup. A microscope vitrectomy machine has to be in a perfect condition, otherwise there's no point in going in and doing things halfway. You have to have an IOL inventory, because most of the times your IOL will be decided on the table, the power. So you have to have a good inventory and great and a lifetime commitment, as these kids will keep coming back for your EUAs, suture removals, glasses change, and squint surgeries if needed in these patients. And small patients needs more patients. You have to be more patient with these patients, and then of course you can get good results. Thank you very much.
And thank you very much, Sir Darren. We've got 20 minutes left for discussion, and would somebody like to say questions, comments?
Yeah, actually, I went to discuss with Dr. Rohit regarding if there's a combined hyper with exotropia. How you are going? You said you will bring the lateral rectus inferiorly and get it attached to the medial side. Is it a combined third and fourth nerve palsy, or what do you think about it? You're unmute. You have to. We can't hear you, Rohit.
You can hear me better now?
Now better.
Yeah. So I was just saying it's not necessarily third and fourth always. In an abducted eye, the fourth nerve palsy may not cause so much vertical deviation. So you may have asymmetric involvement of the vertical recti because they are of two different divisions. So that is often more responsible for the vertical deviations. But yes, for any third nerve palsy, you must check for superior oblique function. That of course is an important thing.
Dr. Sudarshan, have you seen congenital Zika syndrome patients?
Not yet here in
India. They will also have similar features to congenital rubella syndrome.
Of course.
How do you differentiate between congenital Zika syndrome and congenital rubella syndrome?
Great. So I haven't seen any Zika. I've just heard about it, and the picture is similar. The only good thing about rubella is that the retinopathy, which is similar to the Zika, does not cause the loss of vision.
And when you do the rubella IgM for this patient, because if they are coming late, the rubella IgM will be negative. So then you take out the lens and look for the virus, or how will you go ahead?
No. See, by the time these people land with us, they are all IgG positive. IgM is gone because they don't come that acute. And I think if this kids come early, even if you pick up an IgM and see, basically, they are seronegative or positive, it's not going to make much difference. Surgery has to be done. The only thing is that in these patients, you can't do both eyes together, close by. So in case you expect a reaction in these patients, so all these rubella patients, even if they are IgM positive, IgG positive or negative, and if you just have a suspicion of rubella, and as I said, these are the small pupil like a uveitic eye is non-dilating, and they have cataracts, which most of the times they're partially absorbed membranous cataracts. So you need to operate these patients with caution. You need to give higher steroids and cycloplegic post-op, and please plan the second eye only after 1 week once this one settles. Whereas in the normal congenital cataracts, I do it on the 3rd day. First OT 1 day, and after 3rd day, I do the second one.
Okay, and what are your takes on patients who have microcornea with absorbed cataract? What are the syndromes we should be looking at?
Okay, so the most common is a microphthalmous cataract syndrome, which is the commonest one. I mean, if you see, those are the commonest ones. Cause, nobody knows why it happens. Second microphthalmous is your rubella, right? Third microphthalmous, especially if it's a unilateral, is a PFP. Now, surprisingly, PFP, we found out earlier, people thought it's not that common. We found out it's not that rare. So what is happening in these eyes is these are the eyes which at the time of inception, when when there's a retraction of the vascular system at the back, it's about 22nd, 23rd week, it should be over. So once it doesn't happen, that means the growth has stopped there. So the eyeball size will stay that. Why it happens unilateral is nobody can answer that. We've been checking the literature because always they say the left eye is more common, the females are more common. We have bilateral PHPVs also. We get ophthalmic eyes having PFP because ophthalmos came later on and the eye grew. So the commonest they say is a unilateral small eye. So small eye microphthalmous syndrome is the one. PFB is the second commonest we get. And third, I said, is rubella. These patients will also have a smaller eyes. Anything you want to add, Shashikant, to this?
Yeah, actually, we think Loeys syndrome, Hallermann-Streiff syndrome,
Okay.
and a few other syndromes.
Shashikant, the Loeys will have typically anterior posterior conus. That is more common, and that's what we get. So we get conus in these eyes. That the conus eyes are not necessarily has to be smaller eyes.
And Warburg micro syndrome.
Okay, but we don't find much with the Loeys as such. The smaller eyes, I don't know, we haven't found in our studies. Whatever Loeys we got, we picked up because of the conus in these lenses. Yeah.
Dr. Sumita, you said about TRO, which patients we should consider for surgery in patients with TRO. How you assess the inactivity of these patients?
One MRI gives an idea. If you do the muscle edema on T2 weighted images, the fluid versus fat, that gives you some idea. Patients' systemic eyes look usually quiet, not congested, but we really don't have a very good marker for activity. Sometimes the activity can recur, and that's probably one reason why reoperations in PRO for strabismus, especially if the follow-up is longer, reoperation rate tends to increase the more you follow up. So probably yes, but I would look at MRI and look at muscle edema per se as one of the markers. And of course, stable angle is also one marker, indirect clinical marker for no activity.
What is the role of TSH receptor antibodies in these patients?
We don't do it routinely because probably most of it is managed by our orbital thing, and usually they get referred to me only after acute phases are over or active phases are over. Sometimes I see them for diplopia management in the active phase. And I usually take guidance from the orbital surgeons, orbital people before I do the surgery on this.
Okay, and to prevent late seepage of the inferior rectus, do you use the non-absorbable sutures?
I have used both, absorbable as well as non-absorbable. And probably non-absorbable is probably better, but I have used absorbable in the initial part of my career and I have not really seen that much of a problem also. So I think it probably individual thing. But if the muscle is very bulky and probably non-absorbable makes sense. I would be happy to hear other people's comment on this because this is something which there is no clear-cut literature on this. Rohit, Ramesh?
I generally use...
There are very few cases, so our experience is also very limited, but I have always used non-absorbable to obviate the risk of the shift of the muscle. So That's what, and it's in the inferior rectus, so it really does not cause a cosmetic issue, which is a problem if you use non-absorbable sutures in the horizontal recti. Ramesh.
Yeah, I generally use absorbable, Sumita, as you're doing in most of the cases. Even in the last 15, 18 years, I've used the same thing. What I do is I do smaller inferior rectus recession, never more. And I use additional knots. I don't know, additional knots are really evidence-based, but it gives me a lot of peace of mind. Just that take 1 or 2 extra for good luck and then do it. So I have not seen real overcorrections with this. I had 2 patients, I had overcorrection, probably really, really wrong, where I have done 7.5 inferior rectus recession, which maybe in 2004 or 5. So that's my experience with this.
Yes, I think that makes a good point. Inferior rectus, especially in thyroid, probably you should not go just because the angle is 65 or 55. You probably should not go more than 6 millimeter, because if you go more, then down gaze issues are really bad for the patient, and patients, even though they are aligned in primary position, they are usually unhappy with their down gaze, and that tends to increase over a period of as you go into the follow-up.
Yeah, in this kind of cases, we have even the second muscle we can take care of, so that we can take care. With regards to the activity, I just had one comment. Obviously, the clinical evaluation, MRI, and obviously the color desaturation and all that. But of late, the muscle, hyperintensity is one of the things that we can, and also OCT can really tell whether there is some activity going on. In subclinical way, it can tell. So these are just an additional thing. And sometimes you see that crowding at the orbital apex, you can only pick up with the imaging. We can't even see that crowding at that place. Thank you.
Miho, would you like to comment on thyroid? Miho, would you like to make a comment on thyroid eye disease? What do you do?
I use absorbable suture in most cases. And
thank you.
I usually do not go over 5 millimeters.
Yeah. What do you do in Tianjin?
Tianjin?
Yeah, what do you do in thyroid eye disease? Do you use absorbable or non-absorbable?
So,
which sutures do you use for inferior rectus recession?
Inferior oblique weakening procedure. Normally, I do inferior oblique myectomy instead of inferior oblique recession, mostly.
Yeah. And Angua?
I generally use the absorbable suture. I think some of the cases have a delayed overcorrection, but in that kind of case, usually you can find a recurrence of the thyroid eye disease in the superior muscle. So I think that's not the reason for the suture migration. And in my cases, some severe cases, I have to recess over 7.5. I think in some kind of case, you have to relieve the restriction. So I still make a larger recession if necessary. Of course, you need to, in this kind of cases, there will be some limitation of downward gaze.
Dr. Wang, have you with the buccal, have you noticed any superior oblique incarceration syndrome or inferior oblique inclusion syndromes with the buccals?
Personally, I didn't find that kind of cases. I knew that some of the superior oblique muscle may be trapped in the buccal, and we should be careful. And if there's some weird movement preoperatively, we should first check the force duction test and also explore the associated area for these oblique muscles. I think that would be important. But personally, I don't have experience in that.
Dr. Shetty, do you have any questions from the panel?
Dr. Miho Sato.
Yes.
Yes. In superior oblique palsy, if right eye superior oblique palsy, mostly the patient's head tilt to the left. But sometimes the patient's head tilt to the right. How do we design my surgery?
You mean the right superior oblique palsy?
Right
Patient-
hypertropia. Yes,
right hyper,
palsy.
and the problem is in the right gaze more than left gaze. In that case,
Mostly right superior oblique palsy. Right superior oblique palsy. Mostly height tilt to the left. Mostly the height tilt to the left. Right hypertropia. The height tilt to the left mostly.
Dr. Sato, the question is that if there is a head tilt to the ipsilateral side, so if a patient comes with a ipsilateral side head tilt, the side of the palsy,
head tilt is
ipsilateral side instead of the contralateral side, which is the normal presentation.
It's very, very scary case. Yes, of course. Yeah, there are some papers. It should be corrected as a right superior oblique palsy. But usually, I do not have so many patients who had, opposite side of head tilt. I try to wait until the patient get better examination to the old enough. Usually those patients are children, not for acquired, mostly congenital. So I wait until the patient can get older and maybe try prism and to simulate if the head tilt may recover. But I don't remember if I have successfully treated that cases. Their head tilt may remain, and it's very difficult. If there is any idea to go, I'm happy to hear.
So you prefer to wait, observe, not immediately surgery. Thank you so much.
I had some of these patients. When I have this paradoxical head tilt, I almost always try to do the MRI and find out whether there is definite evidence of hypoplasia or aplasia of the superior oblique. These are 100% of the cases I'll get an imaging done. Otherwise, generally in a superior oblique palsy, I don't get it done. Sometimes what happens is they have a very, very tight superior rectus, like sometimes superior rectus contracture can be there. And sometimes I have seen they have a subtle DVD. That's why they have this kind of paradoxical head tilt. In terms of surgery, I have quite a bit of success in a typical management of doing that inferior oblique weakening or the same side superior rectus weakening. They really respond to that unless they have long-standing head tilt where there is a neck muscles are really tight. So in short, I would get imaging done. Just make sure that there is nothing wrong happening. It's just a paradoxical head tilt. And I would do inferior oblique along with the superior rectus of that.
Yeah, usually paradoxical head tilt in a patient, adult patients, usually it is because to increase the images. So I think we should do as normal procedure because, but as Ramesh has told, aplasia of the superior oblique, and Brodsky puts it that if you see a patient with aplasia with superior oblique muscle, you usually see a large XT, large hyper, and amblyopia. That what he says the clinical signs of absent superior oblique muscle. So then the head tilt may not be of any use for this patient because they're not going to get any binocular vision, or it's just a habitual head tilt. Or the second thing may be a combined dissociated vertical deviation coexisting with the superior oblique palsy. And Dr. Sudarshan, do you do optic capture? And if you're doing an optic capture, what type of lens you will prefer? And do you combine with the anterior vitrectomy?
Yeah, it's Shashikant, because that's a good question, because I think recently there's again a sea change. People have started going for 3-piece. So basically, two kind of lenses we have. We have single piece lens, which is all single material, soft foldable. And then you have a 3-piece lens with the haptics rigid and the optics being a foldable. So when you do a capture, my take on capture is that I do captures only once my anterior or posterior of either the rexus is not intact. It's gone big. So in those cases, I'll put the lens and use the capture of whatever rex is intact. I put in the sulcus and capture. I put in the bag. I can capture with the posterior opening in case my anterior capsule runs away. Now, I think what you ask, and the single piece lenses should never be captured because the memory of the haptics is not good. And even if you capture on the table, it might look good, but eventually you'll get in trouble because when there's a peapodding, there's a contraction of the anterior posterior capsules, this lens tends to be shifted out. And in these kids, we don't want to do all these things. Okay, coming to your thing, like 3-piece lenses people are doing with the posterior capsule opening and pushing the lens in, and as young as 6 months for old young kids. And what they say, there's no scaffolding, there's no VO formation, and we've seen few papers coming up. But as of now, I still feel that we are putting an adult lens in a smaller child. So I always do a vitrectomy and do a posterior excess. With that, I get a volume from a lens, the adult single piece lens, to open up in the bag properly and not get decentered. So my take on this is this. But in case I have to do a capture, I'll do it all the patient with the PCDs. Or if I've done a UBM and I pick up a posterior cataract, which is a posterior lenticonus or a posterior pre-existing defect in those patients. Or the third area where I use it when my white to white diameter is less than 9 millimeters and I still have to put a lens in a unilateral patient. In those patients, I put this lens with a capture, a 3-piece lens. Otherwise, most of the patients, we're going single piece lens only. Is it enough, Shashikant? You want me to add something extra?
No, nothing.
Because I think people are coming out with this paper that single 3-piece can be pushed behind the opening without vitrectomy. I've done few patients, it's fine, but it's not a simple surgery. That's why I didn't show it here. Second, I think long-term results have to be seen in those ones, and then we can see. And third, what I say is, in case you have to change or explant these lenses, which could be 1 to 2% of these patients, a 3-piece with the capture at the back might have an issue, whereas a single piece in the bag, you can easily take it out because all these lenses, even after 5 years we removed, they don't have much fibrosis on the surface.
Thank you very much, Sudarshan. Unfortunately, we've run out of time, and we've had a most interesting symposium, experts sharing their wisdom. We've learned that strabismus, there's many ways to try and achieve a good result. Often all we can do is improve the situation for our patients. We have a long way to go to get, we can't offer the 99.9% success that the cataract surgeons can. In pediatric cataract surgery, we've had pearls of wisdom from a very experienced individual, Sudarshan. So thank you all for joining us. And Professor Namrata Sharma, thank you very much for inviting the Asia Pacific Pediatric Ophthalmology and Strabismus Society to do a joint symposium with the All India Ophthalmic Society. Enjoy the rest of the meeting. Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Bye-bye.
Thank you.
Namaste sign.
See you, ma. Miho. Sayonara.
Sayonara. Ni hao.
Bye-bye. Bye-bye.
Bye-bye.
Bye.
I hope by this time next year we can meet face to face rather than on a screen.
Yes.
Yeah, that's great.
Yes.
Thank you.
Martin, you're going to watch the Wimbledon, the Australian Open right now.
Yeah.
Are you rooting for, which guy are you rooting for? Novak or the new chap? I think Novak is going to lose. Most probably he's going to lose this time.
Djokovic.
Are you sure? I think Medvedev is going to get it this time. Let's hope for the best. He had enough. Djokovic's been there for a long time, right?
Doesn't matter. I want him.
Okay. All right. Let's see.
Thank you. Goodbye.
Thank you.
Thank you.
Bye-bye.
Bye.
Thank you. God bless.